I would like to request all of you, please start the camera and be in mute. We are going to start the session within a minute. Sir, it's already time. So shall I start?
Yeah,
Thank
please
you.
start.
A very good afternoon to all of you present on today's session. I am Nishita from ClearNet. Welcome everyone on National Neonatology Forum. Gujarat State Chapter presents Neonatal Pathshala. ClearNet is proud to be associated as a digital partner. Now I'm going to play a very short ClearNet's video. I would like to request all of you, please have a look. Thank you so much everyone for your patience watching. ClearNet is India's largest live digital CME and doctor-generated medical content platform. Now, I would like to hand over the session to Dr. Prashant Karya, sir. So, over to you. Please proceed.
Thank you, Nishita. On behalf of NNF Gujarat, I, Dr. Prashant Karya, Secretary of Gujarat NNF, welcome one and all to today's debate. Now, today's debate is going to be an interesting debate in which we'll be having a talk on resuscitation in the Peri viable period, give life a chance and resuscitate versus look at the reality and leave them alone. To have this debate, we are having two expert faculties with us. First is Dr. Satvik Bansal. Satvik Bansal is fellow in neonatology and he is assistant professor in the Department of Pediatrics, Gujarat Medical College, Gwalior. He is having more than 20 publications in index journals, and many of them are from the PubMed index journals. He's author of 4 books, as well as he is associate editor of one book. He's given many lectures at the national and state level conferences. He has presented many posters and papers at the national and international conferences. And he's a reviewer of European Journal of Pediatrics, INVI, Journal of Neonatology, Journal of Clinical and Diagnostic Research. And he received a gold medal, Dr. James Fleet Endowment Award from IAP in 2015. So we welcome Dr. Satvik.
Thank you, sir. Thank you for your kind words.
Along with Satvik, we are having Dr. Monica Monica Kaushal. She is DM Neonatology and she has done FRCPCH and she's a fellow of neonatology, done a diploma fellowship from UK, and she received a Youngest Scientist Award Asia conference, and she's having a publication in many national and international journals and chapters in a book. She is chief of neonatology and from the Department of Emirates Specialty Hospital, DHCC, Iranian Hospital. And to judge today's debate, we are having a young and dynamic Dr. Manoj VC. He is professor and head of Department of Neonatology, Jubilee Mission Medical College and Research Institute, Thrissur. We all have enjoyed IAP NeoCon this year under his chairmanship this year, and is the national executive member of NNF India for the year 2020, 2021 and 2022. He is a national executive member of Neonatology chapter of IAP, State Academic Coordinator for Advanced NRP, President NNF Kerala for 2019 and 2020, President IAP Thrissur, and Secretary NNF Kerala. He has published various papers in national and international journals, and his areas of interest are neonatal respiratory care, neonatal nutrition, perinatology, and interventions in resource-limited settings. So we welcome Dr. Manoj VC, sir.
Thank you, Prashant. So nice of you. Thank you for the kind words.
So without taking much of a time, I invite Dr. Satvik Bansal to first start his debate topic.
I hope my presentation is
Visible perfectly.
Yeah. Okay. So I would be talking about leaving the periviable babies alone, not resuscitating them. I'm sorry for the disturbance. So, okay. Yeah. I may be sounding like a pessimist, but we have to be realistic. It's not just about resuscitating these babies, it is also about whether we are equipped enough to take care of them and to ensure their intact survival. We'll be discussing this presentation under the following headings. Talking about survival, we know that there are various international studies that have indicated improvements in the survival of most premature babies over the last 1 to 2 decades. But there is a but in this. There are 3 points that we have to consider while talking about this data. First, we know that most of the preterm births occur from low middle income countries, from Africa and from Asia, but there's almost no data on the outcomes of periviable infants from low middle income countries. Whatever small data we have for extremely low birth weight babies suggests that the survival rates of these infants are much lower than that reported from high income countries. And this recently published meta-analysis suggested that establishment of higher level NICUs for these extremely low birth weight babies might impose huge financial burden as well as risk of inequity. The data that we have from India is also very little for extremely low birth weight babies. And whatever data we have, there are 3 points. There are some points that we have to consider while talking about this data. First, this data is from settings which have high resources and infrastructure. The nurse-baby ratio is around 1:1. Then this is not generalizable to entire India. The survival of newborns is still very, very low in this gestational age from these high resource settings as well. And there is no data from an average SNCU from small private setups or from government colleges. We have to understand that there is a great variation in the survival of babies from a high income country and a low middle income country. For example, there is a 90% chance of survival of babies at 28 weeks of gestation from high income countries as compared to a mere 10% survival from a low middle income countries. Therefore, it is high time that clinical and ethical approaches to prematurity and periviable birth should be stopped being viewed through the lens of high income country health systems. Second, there is a wide heterogeneity among different centers and countries in reported survival and neurodevelopmental outcome among the high income countries, even when the resources they have is almost similar. Lastly, there is still a large burden of mortality and morbidity for periviable infants, which their health system is probably good enough to cater to. A recently published meta-analysis from pediatrics from high-income countries in 2019 suggests that the survival without impairment was markedly poorer for infants born at less than 25 weeks of gestational age. More so, at 22 weeks of gestational age, the level of evidence was considered to be low. Now, coming to outcomes, the newborn care programs which have focused on improved survival of preterm babies have led to their improved survival. That is true. But that coupled with loss of follow-up of these at-risk babies, inadequate facility for early detection and management of developmental delays, lack of awareness and training, all these things have led to an increased proportion of population which is at risk of neurodevelopmental delay or of malnourishment, and so much so that around 43% of child population in low middle income countries is at risk of not achieving their cognitive developmental potential, and most major chunk of this entire population is from India. So coming to data from India for outcomes, we have very little data. Again, this was a 2-year follow-up of ELBW infants from a high resource level 3 neonatal unit. At corrected age of 2 years, there was a very large amount of babies who remained underweight, stunted, microcephalic, and wasted, and there was a large loss of follow-up. The same cohort, when was followed for up to 5 years, interestingly did not change things. Again, a large number of them were underweight, stunted, wasted, had microcephaly, and more significantly, there was no catch-up growth noted beyond 2 years of age. Leave alone these extremely low birth weight babies. Let's look at the outcomes of our very low birth weight babies. Again, these are the studies which were conducted in a higher resource setting. There was again poor growth noted, with about 2/3 of babies being underweight and stunted. Nearly 50% had microcephaly and wasting, and there was a large loss of follow-up. So this was a recently published predictive algorithm to stratify newborns for child undernutrition in India. It was based on National Family Health Survey 4. And this algorithm considered a birth weight of less than 1800 grams to be one of the factors for childhood undernutrition. So coming to other problems related to prematurity, India accounts for nearly 10% of worldwide estimate of blindness and visual impairment due to retinopathy of prematurity. And this is because of increased survival of preterm babies, and that coupled with low coverage of screening. So we do not yet know about so many long-term effects of these extreme prematurity and low birth weight, and the data as well as long-term impact is unknown. So we don't have the data for it yet. There are certain ethical concerns also. The ethical framework which works in a high-income country will not work in a resource-constrained setting, and it's not well studied also. And not even the thing does not end there. We do not have the data on what works in a low-income country from an ethical point of view. Whatever small data or little data we have gives us 4 major themes. First, there is a higher threshold for treatment. There is an acceptance of futility for many premature infants. There is lack of resources and inappropriate staffing, and multiple factors which were external to the predictive clinical survival influenced the treatment decisions. There are numerous ethical challenges in our scenario. There is an inadequate system of supporting children with disabilities. Families are poorly prepared to take on such a burden. The entire family spend their income and even acquire new debt to take care of a baby who may not even survive or survive with great disabilities. We have to have effective resource allocation. The extended elder family members are the primary decision makers. The follow-up is universally inadequate. Therefore, there is no formal consensus or guidelines. General discrimination is still there. The families are less interested in intensive care for girl babies. There is a poor follow-up. There is a risk of neonatal abandonment if you force these families too much, and women are blamed for a girl child. India is further a cultural melting pot where women are blamed for a preterm neonate. Infants with disabilities are viewed as sin or punishment from God. There are different cultural norms for paying the first delivery or the second delivery or a girl delivery or a boy deliveries. So there are so many potential family burdens and social stigmas which needs to be taken into account when we are talking about ethical framework in a low middle income country, especially in India. To make matters worse, there is a critical deficiency of healthcare personnel. The medical professionals are poorly trained in ethics and communication. There is no database for outcomes of peri-viable infants in the country. Summarizing, the ethical principles of medical care, that is autonomy, beneficence, maleficence, and justice, do not work in a low middle income country like ours. And we need to develop our own framework for approaching resuscitation decisions for extremely premature infants. Coming to cost, NICU cost increases with the decreasing gestational age and birth weight, so much so that the most premature babies forms the biggest burden. It doesn't end there. There is a disproportionate use of resources. There are a huge burden of post-discharge cost, and there is a concern of decreasing overall economic productivity. Coming to the Indian scenario specifically, there is an extreme shortage of beds. The standard of care, which is comparable to a developed country, is very restricted to few SNCUs around India. And with increasing personal wealth and lack of social awareness and increasing social awareness, there is an increasing private demand for standardized care. And when that is coupled with an absence of widespread insurance coverage, leads to an inequitable distribution of such cost-intensive healthcare. These pictures are from a tertiary care government unit. And this will tell you, or you may appreciate the extreme lack of resources and overburdening of the system. And with this much lack of resources and overburdening, we are here talking about allocating the scant resources that we have for babies who may not even survive. Coming to the guidelines for peri-viable resuscitation. The guidelines in many countries are based on gestational age, which leads to uncertainty. It's not reliable for prognostication. Unfortunately, there is no perfect method. So it is better to consider several other risk factors along with gestational age. Few of the guidelines that have come now take into consideration the risk factors, such as the South Australian Perinatal Practice Guidelines and the British Association of Perinatal Medicine Guideline. But that is very less. So what does it all mean? We all want to, or we all aim to practice evidence-based medicine. But evidence-based medicine has three pillars: individual clinical expertise, best external evidence, and patient values and expectations. And when we take care, when we look at all these three pillars, we find so many caveats here. So it is suffice to say that resuscitating peri-viable babies is not evidence-based as of now in a country like ours with limited resources. So finally, do we have the evidence for our own country in a low middle income setting? No. Do we have the infrastructure? No. Can we cover the cost? No. Can we ensure long-term and short-term support? No. Do we have any country-specific clinical and ethical guidelines? No. Are we even able to ensure satisfactory outcome of our VLBW babies? Absolutely not. Therefore, then is it justified that we resuscitate these babies, save them, and then leave them to be malnourished, mentally challenged, and blind? We have to understand our limitations. The babies may be ready, but we are not. We have to focus our resources on babies who we can actually save. Thank you very much.
Thank you, Satwik. Do we have Dr. Monica?
Yeah, unfortunately, sir, she is having some issues with the net and she's not able to join. We are just contacting her on a phone, but then you can have a question and answer with Dr. Satwik.
All right. This happens sometimes in a court of law. You have the public attorney defending for the state, and the defendant fails to produce the advocate. And here the defendant is unfortunately our poor peri-viable baby. So in this special circumstances, I would like to ask the public prosecutor a few questions. Are you ready, prosecutor?
Sir.
All right. That was in a lighter vein. Just to wind up we will take this discussion to a next level. The very idea of having debates in academic sessions is because the whole concept is not black and white. In neonatology, all the more so, we do not have black and white concepts in most of things, and there are lots of shades of gray. And to tide over or to sail through these shades of gray, we need to look at the pros and cons. So there can never be a right or wrong answer. And I should, first of all, I would like to thank Dr. Prashant Karia and the whole team, Pathshala, for asking me to be the judge of this, and then congratulate him as well for selecting this topic. This is one of the topics that that never runs out of steam. All the it is there in most conferences. I remember at the onset of COVID in 2020, when Professor Sushma Nangia conducted the same, it was the Indo-Norwegian conference, and I was actually defending for the neonate. So, so this is a debate, and then at that time, Professor Ola told us in that he had the previous year he was defending for the neonate. So this is a topic that is every time it's applicable. Why is it so? Because the peri-viable period keeps changing. So we do not have a clear-cut definition. So for practical purposes, at this point of time, I believe peri-viable period is in a country like ours, it means something between pre-viable and post-viable. So something between 22 and 26 weeks. So we are talking about 22, 23, 24, 25, and if at all 25 weeks. Fetus is born at these periods of time. So having defined that, we still do have some more variables to define before we say, is it right to resuscitate? One of the points that Dr. Satwik beautifully brought out was that, are we ready? The babies are ready, are we ready? So, from the defendant's point of view, the question would be, is it my fault that you are not ready? Is it my fault that you do not have, you are not totally prepared? Is it my fault that I am born in a setting like you argued for LMIC? That you are not ready. Had I been born in another country, had I been born in Iowa or Japan, the two places with the maximum survival rate, they would not have asked me the same question. So is it not my fault? So what is the answer to that question, Satvik? Forgive me for arguing. I'm being. I mean, probably I would pass on the judgment that being a judge at the end. But then this is to argue the other side, just to see the other side.
I completely agree with you, sir. And I am also on the side of these babies. Let me first clarify.
So you give up your case?
I am for no, sir. I am for these babies, and since I am for these babies, I believe that saving mistake is a bigger mistake than a letting die mistake. So I am for these babies, and therefore, given the scenario that we live in, we have to manage our resources, or we have to manage according to the settings that we have. Yes, it is right in saying, you are right in saying that if these babies were born in states or in Iowa or in Japan, probably we may not even be having this debate for this particular age group, because the guidelines would be to resuscitate or would be stringent enough. But in a setting that like ours, where we really don't have resources, as you would have seen, for receiving phototherapy in a single warmer, there were 8 babies. So the dearth of resources is so much that we have to have a broader outlook rather than trying to save a single baby, allocating the resources to that particular baby, and more so with a high chances of that baby being be surviving with a great disability or not surviving at all. So yes, it's not a mistake of that particular baby, but it's not the mistake of so many other babies who would not be receiving the resources because of that particular baby. So I know there's no right answer to it, but we have to choose lesser of the two evils. So we have to decide whether we have to save a single baby or a number of babies.
Point well taken, Satvik. So probably what Dr. Satvik was trying to emphasize rightly was that utilization resources should have its own justification. So probably this question would again metamorphose into another way. Can you play God? Can we play God and decide this baby is not going to have a good outcome, whereas if you are not even tried? So do we really try? So probably the via media would be like, you look at the results in your center. If you have a reasonably good chance of survival, intact survival, then again, can you take that decision? So one of the things that probably was left out to strengthen your argument was parental consent. So discussing with the parents is one issue which is the most important thing as where the peri-viable period decision making is concerned. Whenever if it is not, if the baby has crossed the peri-viable period, then yes, definitely we would like to the state, the right of the life is the property, the life is the property of the state. So the right to end and take life is the decision of the state. So parents may not have role if you can take out that financial burden from the whole scenario. But in peri-viable period, it is mandatory that probably we take the consent of the parents or discuss the consequences. When you discuss, another point very beautifully brought out by Dr. Sativ is the data that he gave. But the problem is that the data we have is insufficient to India is just not one country. It's a heterogeneous representation. You have centers of excellence and you have centers where primary care itself is lacking. So we need to individualize this question, ask this question in your own unit. So not only the gestation age, the peri-viable period in a unit will be different from peri-viable period in another unit. So there are various other shades of gray that do come into this debate. I'm so sorry that Dr. Monica is not there. Otherwise, we could have had the some more insights into this. And Dr. Prashant, she's still not traceable, or we continue? What do we do now?
We continue, sir. She is
All
not
right.
present.
All right. So one of the things what we just now said is this percentage any significance? My baby is my only percentage. So I may be falling in that 1% of babies who survive intact. So as a parent, again the same question back to what you started, Satvik. Like, is it my fault that I am born here? So do we give a try at least in this, or you are definitely you feel that no, this the resource cannot be. Suppose the sender has 50% chance of good outcome, and then the parents do want to go all out. Their baby is born after a very protracted, tortured phase, and then of waiting, and then treatment for infertility, and you're getting a baby, and parents are saying, come what may, I want the baby. In such a scenario, would you want to try, or would you want to still make them see the reason that there is always a 50% chance that this baby may still be neurodevelopmentally challenged later and risk of even greater evils like cerebral palsy later on? What do you feel now?
Sir,
So
again,
before Satvik answers, one question which is there from the chat box regarding the same only. Satvik, there was a study published in Indian Pediatrics. It says that the rate of survival of a discharge of a newborns who were delivered before 23 weeks was around 23 to 27%. At 24 weeks, the survival rate was 42 to 59%. And at 25 weeks, the survival rate was 67 to 76%. This was a study of around 300 newborns. So the question is very straight. If the survival chance is more than 50%, that is seen that 67 to 76% at 25 weeks, why should not I try?
Sir, again, there are two things to this. First, this is a data from how many centers or a single center. Again, as Manoj sir rightly said, India is not even a one country, it's so many countries there. So it depends on your own unit, number one. Number two, again, these are discharge rate. These are not rates at 5 years, rates at 2 years down the line or 10 years down the line. So our aim of resuscitating is to ensure intact survival or intact long-term survival, which we do not have the data for yet. And the whole point of discussion is this, that we have to have some data, or we have to have some knowledge as to how to move ahead for these babies. Now coming to Manoj sir's question, that yes, again, it depends on which unit I am working in. If I am in a unit which has a 50-60% survival, again, those units would not be many, considering if you take the entire India and take out a proportion of units, number of tertiary care units that there are in India, and the number of tertiary care units having a 50% survival at 25 weeks of gestation, you will get an answer of as to what is the percentage of those units in the entire country are. So here we are talking about what the entire India, or the guidelines that should be pan-India. So we cannot have a guidelines which most of the units cannot adhere to. or will found lacking to adhere to. So it depends on which unit I am working, what are the parental concerns, and their interest or their need, or how much invested they are. The point being that even there are scenarios when the baby is around 23 weeks or 22 weeks is with you, and the parents are not invested that much, or they are not having any information as to take a decision, or they are not educated enough to take a decision, or understand the scenarios, or understand the familial burden and the financial burden that may later on come on the family. Lastly, to actually counsel these parents, we again don't have the data from as such. We want that data from such centers that we have, even if it is a high resource setting. If we have a lot of data from high resource settings, that will at least give us some idea as to what to expect, and we can form a better transport referral to certain units, and all those things that can come into the picture later on. But right now, considering the given scenario, we don't have data. And to actually decide on whether to resuscitate or not will need specific knowledge about that particular center, and the amount of resources that are available at your own disposal with the parental concerns.
Thank you, Satik. Well brought out. So finally, what would be your, suppose I am the parent, and then your unit is one of those which has 50 to 60% survival rate, and then would you want to convince me not to go ahead with registration, or would you want to, because this decision has a time frame. There is something we are all aware of, the golden minute and the golden hour. So, like, would you want to initially resuscitate and then later on withdraw support, or would you still want to discourage me from asking my kid to be resuscitated?
Sir, I consider that if I am working in a unit which has a 50-60% survival at 25 weeks of gestation, we will have a lot of time to discuss it antenatally. So we can have a specific, we can have detailed discussions with the parents, and then formulate an individualized plan for them, rather than having a clear-cut distinction between resuscitate or not to resuscitate. And since those units, generally the parents coming to those units are also of a considerably more educated, and probably could understand, or we could reason them in a more effective way as to the situation that can later on come, and then decide. Because as you said one point, that they had gone to a lot of turmoil for this baby, but we have to consider that that turmoil is less as compared to a turmoil if they have a baby who is having cerebral palsy or is severely neuroderanged for a very long time.
But who is to decide that?
The
Will you
parents.
be the person,
Parents.
or will you leave the decision to the parents?
I'll leave the decision to the parents.
Yes, point well taken. So it has to be, we cannot, whatever circumstances, we cannot play God. Our duty is only to present both sides of the coin and then let them take the decision. But it's our due, we'll be failing in our duty if we do not tell the grim side of resuscitating these babies. If the parents go ahead with resuscitating, what is in store for them? They have to take an informed decision finally whether they need to go ahead and do it or not. And most of the time, as Dr. Satik mentioned, you have resources which are limited, and then if like for example, you have only one ventilator that is free, and then you have 3 babies waiting, and then this is the first one that comes. So like there are so many issues that will creep up. So this is a question that is answered differently in different scenarios, and I really like the way the evidence-based medicine was very clearly put up. All the 3 pillars, all the 3 aspects should be met before you consider your decision as evidence-based. The parental expectations do have a place in that. Any other questions? I am not able to see the
Yeah.
question chat box.
So the question on YouTube, Satvik, the question is, Dr. Urvi is asking, what gestation is still non-viable for India in court of law? Plus, any weight criteria is there or not?
So there is no clear-cut answer to that particular question. And again, we don't have any specific guidelines for India as such. Right. So as sir rightly put, it varies even from unit to unit. So for India as a whole, we don't have any guidelines as of now. There was a case 2-3 years back where a baby was not resuscitated in Delhi or somewhere. So these issues come up quite infrequently though, but they come up, and that's why it is necessary to have some sort of guidelines from various societies or from government itself, so that as doctors we are having something which we can fall back to.
She's just adding to it. Less than 500 gram is considered as abortion. So should we go for resuscitation or not?
It again depends from unit to unit. When I was working in UK, we saved babies who were around 400 grams old. But when I'm working in India, in my setup, I'm not sure for babies who are 28 weeks gestational age or 30 weeks gestational age. So it's absolutely depends on where you are. In India, there is no specific guidelines as such for any birth weight or for any gestational age that I am aware of. Manoj sir may add in it if I'm not complete.
No, I would like to take the thing. If you are asking what is the guideline for India, probably the most accepted guideline probably would be to take any baby below 26 weeks in the peri-viable period and take the parents into confidence when you resuscitate. Show them your statistics, your unit statistics, and if possible, national statistics, whatever is available. We have a scarcity of data that is available in our country. So whatever data you can show, these are from these centers and this is our unit. So the first thing is you should have your own data. If you have not even thought of resuscitating babies at 24 weeks and then at 22 weeks fetus is born, you need to be very, very frank with the parents. The final decision has to be with the parent in the peri-viable period. That is probably we live in an era of medico-legal scrutiny. So this is very, very important aspect. And as it is, we say 22 weeks and above are peri-viable in various centers. So probably 22, 20, this is what I began my statement with. 22, 23, 24 and probably 25 weeks babies are peri-viable if you do not have any unit policy. If you have a unit policy, if you have justified your policy, then fine. If not, this is what you can go by. Weight wise, I do not agree with that 500 gram. There are centers which do these things. Again, you need to have your own thing. Weight is going by the weight criteria, even though it has more data to back it up, is less scientific than going by the gestation rate. So these need to be kept in mind. Resuscitating in neonates continue to be a gray area in the peri-viable period. Only thing, the peri-viable period may change, but the area decision is always amenable to change. Like the unit policies. And of course, another point which Satvik brought out, the ethical framework. So you need to adopt accordingly. So any other questions?
No.
So Monica is still not traceable.
So Monica is still not there, but luckily, I think we are having a time, sir, and we will just utilize this time by showing the Monica's presentation. Is it fine?
Yeah, please go ahead.
So I just received, this is the beauty of what you can say on net, that we received her presentation, but we are not able to connect to her. So this is what she has prepared: resuscitation in the peri-viable period. She is just saying a case. A call came to you from the obstetric colleague. A mom came in labor and bleeding at 23 weeks of gestation. What would you tell her, and what is the age of viability? Now, while going to this, we must have a risk-based approach while doing a decision making. We must assess the baby, we must counsel the parents, and agreeing and communicating on a management plan. Now, assessment of the risk for the baby, gestational based risk assessment and modified risk assessment. So if we want to define a peri-viable period, that is challenging because the defined level of maturity below which survival and or a normal development outcome is unlikely. Survival is the objective and normal developmental outcome that adversely affects quality of life. So we try to define a gray zone or peri-viable period and discuss, negotiate and compromise on these limits. Now this gray zone means too immature to have any reasonable chance of survival without deficits. That is there. Second is mature enough to have a reasonable chance of good outcome. So that is there. Now, again, going to a gestation based risk assessment and mortality. What is viability? That gestational age at which there is 50% chance of survival with or without medical care. Under current conditions, viability in a developed countries is between 22 and 24. If we define prematurity, extreme premature are less than 28 weeks, very preterm 28 to 32 weeks, moderate preterm 32 to 34 weeks, and late preterms 34 to 6 weeks. Now, estimated survival if active care is provided. I mean, this is a data of a UK. Again, the data which we discussed that 40% of those babies between 23 to 23 plus 6 weeks who received active treatment after birth, and it showed the increased survival rate which was there. And as the age of maturity is increasing, the survival rate is increasing till 80%. So that is there. So that is one thing. We are having initially facility of CPAP and ventilators in early 1980s, and then there was exogenous surfactant in early 90s. Then early steroids came into place in 1990s. Avoiding postnatal steroids in early 2000 and targeted oxygen therapy came into mid 2000. And now we do have a delivery room CPAP, Ensure and Lisa in 2005 to 2010. So that is actually increasing the survival. Now, gestational age at which a newborn had a 50% chance of survival in North America was in 1940s 32, which came down to 26 to 27 weeks in 1980s, and now in 2000 it is 24 weeks. In 2022 it is 22 weeks. So that is the beauty with the interventions with which we are having all this. Survival of inborn extreme premature infants was increasing from number of 22 weeks, it was 58%, and at 24 weeks, it increased to 85%. So that is there. And this is a hope journey which is going on. Now, when Satvik said, why will you not save? The finance to allow them to save is not available. Fetus does not have right to live, no medical legal support. Expertise is not there, and worried about neurodevelopmental outcomes. So this was a study in which between January 2017 to 18, extreme low birth rate babies were seen, and at gestational age of 23, 50% survived, and normal at 18 months. So was having an intact survival. And this is a data of Urban Newborn Care Center that is from Ahmedabad. If we talk about the data between January 2012 to 2016 at Surya Mother and Child Care Hospital, at 24 months, the survival, number of babies admitted were 54, and 48% survived with normal neurodevelopmental outcome at 18 months. So in India also, yes, 50% survival is there. Now, when we talk about the finance, the newborn is saying, look me in the eyes, don't let me die. I can't lose my baby just because we can't afford to save the life. Survey of academic and private neonatologists in USA was done, and they said they have given a preference to a parental preference for doing a resuscitation. I would withhold my resuscitation decision until I saw how the infant looked, and I would resuscitate initially, but I might consider after I saw how the infant responded. Can I define peri-viable gray zone better now? So birth between 22 to 23 plus 6 days will be a peri-viable. Birth weight between 400 to 500 gram. Survival and long-term outcomes are overall poor but difficult to predict. The line between patient autonomy and medical futility is blurred in this gray zone. Now, this was the outcome of the fetal infants around 4,172 infants with birth weight between 4,401 to 500 grams at the Oxford network experiences. Total newborns registered were 4,172 and died in delivery room were almost 50%, 2183. But survival to delivery room to an ICU was 2183, and out of that, almost 50% again died in NICU, but survived to NICU discharge was 690. So almost 20% more than that were able to survive, and the success rate was actually high, and the success of this depended on a female gender, cesarean section, small for gestational age, and prenatal steroids coverage. So that was there. Fetal assessment near limits of viability was done, and then this was the accuracy. And modified risk assessment like fetal factors like male, sex, multiple pregnancies, congenital anomalies, and poor fetal growth may be having a less better outcome. The clinical conditions like prolonged pre-labor rupture of membranes before 24 weeks of gestation and clinical evidence of chorioamnionitis was having a worse prognosis. And the clinical settings, the survival is highest at this extreme premature gestation in centers with experienced staff and high patient numbers. Now, this was the obstetric factors. I mean, the infant mortality within first 24 hours in a 401 to 500 gram weights who were between 23 to 25 weeks of gestation, and majority were having chorioamnionitis, rupture placenta, and the multiple birth. If they were given delivery at the level 3 hospitals were given tocolysis, antenatal steroids, and cesarean section, then overall survival was better. Now, effect of fetal compromises on survival, a major anomaly, congenital sepsis, chronic intrauterine infections, intrauterine drug exposure, congenital anemia, severe growth restriction, fetal acidosis, and cardiorespiratory and neurological depression in the delivery room was having a worse prognosis. Absence of fetal compromise has a beneficial impact on outcome at a peri-viable gestation. If we see 142 babies, 99 were having no fetal compromise and 43 had only one problem, then the overall outcome at between 23 to 25 weeks was better. If they were given antenatal steroids, then also the outcome was better. Does infant status at birth determine the outcome? Again, this study shows that 102 preterm infants with less than 750 gram of weight, 65 survived and 37 were not able to survive. But the birth weight, more the birth weight, I mean, that was having a good effect. What is the disability rate? Is the rate increasing? The proportion of newborns surviving without disabilities has also increased. If we see mild or no disabilities, then the rate is still there. Moderate disabilities again was there in around 30%, and severe disability was there. But as the age of gestation increases, the severe disability rate was also decreasing as low as to 10% in 26 weekers. The Bailey Developmental Index in premature survivors, this was a cohort in 1990 and 2000s. An outcome of extreme prematurity showed that two cohorts born 20 years apart, and this study says that the survival for extremely preterm infant increased from 82% to 93%, and perinatal morbidities decreased, and neurodevelopmental outcome at 24 months of age was improved. This was again a Epicure studies which showed a functional outcome was good, and 2-year neurodevelopmental outcome in children again born extremely preterm, that was also showing that it was having a good neurodevelopmental outcome. So this study says that within a decade after lowering the threshold for supporting active treatment from 25 completed weeks to 24 completed weeks gestation, 62% of the extremely preterm survivors did not have any impairment at 2 years corrected age. The change in threshold and subsequent improvement in survival at 24 weeks have not been accompanied by a large increase in survivors with neurodevelopmental NDI. Adult mid-30s summary of McMaster studies, they showed the comparison between ELBW versus full term, that similar level of education was there, no significant difference in rates of employment or income, no difference in living arrangements and reproductivity, higher rates of psychiatric problems, lower risk-taking behaviors, and they were the productive members of the society. So, are we accurate in predicting the survival and long-term outcomes in a premature infants? So, the comparison study was done for the survival, and that was uh, seen. And at that time, the thing was gestational age is not a good predictor for the neural developmental outcomes. In India, the viability is still in a gray zone. Disability. So what? That is the question for the parents. The parents, which we're saying that even if it is a disability, so what? So that is there. And gestational age is alone not the sole predictor. If we see between 22 to 23, 4 weeks, there were no impairments in almost 50%. Around 20% were having a mild impairment, and few were having a moderate to severe impairments. But if the age increased to 24 weeks, again, the rate was almost, same. So outcome of a newborns with birth weight of 401 to 500 gram, that showed that compared to patients who died in the delivery room, neonates who survived to be admitted in an ICU were more likely to be female, 58% versus 49%. They were small for gestational age, 56%, have received prenatal steroids, 61%, and have been delivered by a cesarean section, 55%. So again, gestational age is not the sole predictor for the survival. This was the publication in a Science Direct that end of a life decisions for extremely low gestational age infants. By simple rules for complicated decisions should be avoided, and it said that official pronouncements of professional bodies, willingness of obstetrician to actively intervene, birth in tertiary care centers, gestational age, weight for gestational age, singleton female factor, and exposure to prenatal steroids was having a better outcome. Like socioeconomic factors like higher family income, education of a mother, and a two-parent family, absence of perinatal complications, given breast milk, and a KMC also having a good indicator. If we talk about the disability, then with efforts we can convert this disability into abilities. So if we talk about the boundaries of viability, again, as sir said that in Japan, the limit of viability changed from 28 to 24 completed weeks of gestation in 1977. And subsequently in 1991, it has changed from 24 to 22. So this is what by experience they are changing the age of viability. And India, we are still in a phase in which the different centers are having a different outcomes. These are the some miracle babies who were saved as extreme premature with the age of viability of around 22 to 24 weeks, and they all survived with happy families. So thank you so much to Dr. Monica for providing this. And statistics says that I'm 1 in 8, but my parents tell me I'm 1 in million. So this is what, and for this we must continue to resuscitate in Peri viable period also. So thank you so much for listening to me on behalf of Dr. Monica. Yes, sir.
Well, I think all the aspects have been covered. We just discussed a lot of points. Satvik, you want to finally, before probably we make I make the final judgment. Do you want to do any rebuttal?
Sir, we have already discussed all the points. I would just like
we
to...
discussed, but Satvik, we are sorry we received it late. There are some technical issues, but then I thought because we received from her side, it's better to present in 10 minutes.
Yeah, sir, absolutely. So, sir, even the data from what we see in the presentation was that there is so much data from the developed centers which tell us that it is possible for babies in the periviable period for them to get resuscitated and for them to have a good outcome probably later on in life. The question being whether we are equipped enough in India to have that kind of support, and we are equipped enough to give that kind of support to these babies, given the resource constraint that we have. What we see is even in pediatrics, there was a recent meta-analysis which was published in 2019, which considered the data from high middle income countries, and it suggested that I've shared in my presentation also, that it suggested that the survival without impairment at 25 weeks or less was poor, was 1%, 2%, or very less. Secondly, a recent study from BMC Pediatrics to 2022, it gave an indication that there was a big survival gap even in a low and middle income country. Still now at 28 weeks of gestation, the percentage of survival of the babies is only 10%. If you take the entire data, we are not talking about single centers. We are not talking about centers of excellence. We are talking about the country as a whole. We are talking about centers which constraint of resources. So until and unless we have a good program of neurodevelopmental care, until and unless we have good ethical support to guide us, and we have resources which we can effectively allocate to these babies rather than to certain other babies who may survive, who have a much greater chance of survival, I would say that we have to stay put. But then again, it depends from center to center.
Excellent. So I think we have covered almost all the aspects, and as we began this debate, there are a lot of shades of gray in this. So there is no right or wrong answer to this. We cannot say we cannot resuscitate, or we should resuscitate. So your center's capability, the parental expectations, all do come into play, and then only the decision can be made. Allocation of resources have to be done, and that is where the ethical framework comes. Are you justified in denying treatment because somebody else is waiting? So these are issues which will make sure that this topic will continue to be debated in the years to come. But we hope that all the aspects have been brought out so far in a comprehensive manner, and probably one point which probably still is a pointer for it is not part of the debate, which probably Dr. Satik, since Dr. Monica is not there, I from the it's always the comment, the duty of the judge to finally make or rather parting statement, something like a statement for you to think over. Like, until we decide to resuscitate these babies, we will be stuck at this level. Only if you go through the learning curve, you go on to the next level. So this probably may be another area where
you don't drive a supercar with your brakes fail.
Excellent. The thing is, there is always a provision to rectify your brakes, and this is where because we only can improve our center, and the whole idea of this discussion is that collect your own data in your center, look at what are my problems, and then try to improve upon them. Until we do that, we will be stuck in the same era. So I think we will close the discussion at this. Over to Dr. Prashant.
Thank you so much, sir. And so sorry for the technical glitch which has happened.
But thank
you so much, Satvik, that in spite of believing that you must resuscitate the newborn in a peri-viable period, you presented the data so beautifully and shown us our limits, that these are the problems which we are facing, and for this we should not resuscitate. So thank you, Dr. Satvik Bansal, for participating in the debate, and NNF Gujarat presents the certificate of appreciation to you. And thank you so much to our judge, Dr. Manoj VC sir, who was not only a judge but a defender also. So thank you so much for being in Neonatal Pathshala. And thank you to Monica for sending the presentation, though she was not able to join due to some technical issues. She is in Dubai at present, but then also I presented in 10 minutes whatever I can read from these slides. May not be a perfect ones, but then yes, the slides were beautiful. So thank you so much to Monica also. So thank you. We will be meeting next Wednesday at the same time, 3:30 to 4:30, in a different neonatal Pathshala topic. Over to Nishita.
Thank you so much, sir. It was really a wonderful presentation shared by Dr. Bansal, and Monica ma'am has also shared lovely presentation, though she is not in this session. Thank you so much, sir, for conducting this session. So with all of your due permission, shall I conclude the session here now?
Yes. Yeah.
Thank you everyone for joining.
Bye bye.